This discussion is for Chapter 9 on anxiety disorders and mental health nursing from Cynthia Chinchello. So let's get started talking about anxiety disorders. So when we think of anxiety, it may be a little tough to kind of explain, but so sometimes it can be a vague, uneasy feeling, an emotional feeling. Maybe there's response, it could be a response to danger or perceived danger. Okay, so how does it manifest itself? Thoughts and feelings, behavior. The person's whole mood, affect, their whole state of being is affected by this anxiety. Sometimes a patient may exhibit automatic relief behaviors and they may not even realize they're doing it. So these automatic relief behaviors are unconscious behaviors aimed at relieving the anxiety. Although the individual may be unaware of their actions, others may be affected. So, for example, if a person is sitting in a room, a classroom, a conference room, and they're clicking their pen because they're nervous because they have to give a presentation, they may not realize they're clicking the pen, but the person next to them may say, okay, look, you've been clicking this pen for 30 minutes, you need to stop. Okay, so some other examples of automatic relief behaviors could be jaw clenching, finger tapping, as well as fidgeting. So let's take a look at the types of anxiety disorders. So there's generalized anxiety disorder. And in this disorder, the individual experiences an increased level of anxiety and worry about various situations on most days over a period of at least 6 months. And that's very specific for the diagnosis. So the individual has difficulty controlling the anxiety and experiences considerable discomfort, lack of concentration, and impaired ability to function that cannot be attributed to physiologic effects of a substance or another medical condition. So very specific requirements. And something to understand is that mental health conditions, the Bible, so to speak, is the DSM-5. And that's the diagnostic statistical manual that gives us a list of the criteria that must be met for someone to be diagnosed with a mental illness, and that is the DSM-5. Okay, so if this person has generalized anxiety disorder, there's some signs and symptoms that you may see with this person. They will have chronic excessive worry and anxiety with no particular stimulus. They can have negative self-talk, difficulty falling or staying asleep, increased startle reflex, feeling on edge, unable to relax. They may experience restlessness, irritability, inability to control their anxiety, anticipating the worst, inability to concentrate. Also, they may experience physical symptoms that are called somatic. They may have tremors, chest pain. They may hyperventilate. They may experience muscle tension, headaches, fatigue, breathing difficulties. They may also experience GI disturbances. They may have urinary frequency, and they may even grind their teeth. Okay, so this slide kind of gives you the breakdown of some of those symptoms that you can see, and that's in your textbook on page 129, box 9.1. Okay, and so this individual that has this anxiety, generalized anxiety disorder. It may be cyclical and it tends to be chronic over a long period of time. And a lot of times it coexists with depression. That is a common finding that you can find in your patient that has generalized anxiety disorder. Okay. So let's talk about panic disorder. Panic disorder is when a patient has these reoccurring unexpected panic attacks. And a panic attack is described as an intense feeling of fear or terror that occurs suddenly and intermittently without warning. The individual experiencing the panic attack is unable to determine when these attacks will occur or reoccur. So when when the individual is unable to connect any particular stimulus with a panic attack, this is known as uncued. So there's no particular cue or trigger. If an attack can be linked to a trigger, maybe I don't like going to the dentist, right? Then that attack is said to be cued, okay? So some people may experience a single attack while others go on to develop panic disorder. So again, this panic disorder is characterized by recurring unexpected panic attacks. The frequency and severity of these attacks may vary. So some people may be able to endure brief exposure to the situation that causes panic. Others may not be able to expose themselves to the situation at all. And so when they are not able to expose themselves to the situation at all, this is the consequences of this disorder are much greater because it may be something, again, like going to the dentist or getting vaccinations or going to school for some children. And so this affects their ability to carry out their daily lives or their ability to get a checkup or to receive these vaccinations. Okay, so all important things. So let's talk about the signs and symptoms of panic disorder. So rapid pounding heart rate, increased perspiration, chilling or flushing, tingling, numbing of the hands, shaking, nausea, chest pain. They may have a feeling of being suffocated or being out of control, a fear of dying or having a heart attack. They may have agoraphobia, and agoraphobia is an avoidance of certain places or situations where escape is impossible. So individuals may want to avoid crowded places, not go to the mall, to the movies. So those are examples. The patient that has this panic disorder may also experience depression. So really important to understand this. And whenever you have a patient that has this panic attack, the nursing consideration, and that's going to be a general theme for your nursing considerations for your mental health patient, is to keep them safe. Because when the patient is having these panic attacks, they are not thinking clearly, they are not able to receive information and process it. They will not be able to follow commands. So the nurse's responsibility is to keep the patient safe, okay, to keep the patient safe. That's really, really important. When we talk about agoraphobia, again, that is, okay, I don't want to be in a situation where I can't escape. And this may affect the individual because they may not be able to go to the supermarket. They may not be able to carry out their activities of daily living. They may not be able to go to school. They may drop out of school. They might not be able to hold a full-time job. So all of these things can happen if your patient has agoraphobia. Okay? And again, it's the fear or avoidance of certain places because they cannot escape or escape is impossible. It seems impossible to them. Now let's talk about specific phobias. So when we talk about specific phobia, this is characterized by an excessive and persistent irrational fear of specific objects or situations that pose little threat or danger. The common categories of phobia include things like animals, heights, water, storms, blood, needles, flying, or spaces, specifically closed spaces. So let's talk about the most important thing in a nursing kind of setting. If you have a patient that is afraid of blood, that could be a cause for them to faint if you're drawing their blood, or if they have a wound. If you have a patient that's afraid of needles, that could be a cause for concern because they may be really resistant to receiving vaccines or medications. If you have a patient that is afraid of closed-in spaces, like claustrophobia, that's going to be a concern if they're having an MRI or a CT scan. So you kind of have to, ask these questions and kind of figure out and let your chain of command know. Because if this patient, for example, is claustrophobic, they have to have an MRI, they may have to be sedated prior to having this procedure done. So that's really important to understand. Let me just go back. So there's different kinds of specific phobia. There's actually hundreds, and we're not going to focus on all of them in this particular discussion, but I'll just mention a few, or several actually. So fear of germs is mysophobia. Fear of spiders, arachnophobia. Fear of snakes, ophido, ophid, ophidiodiophobia, and fear of heights is acrophobia. Fear of thunder and lightning is astrophobia. Fear of confined spaces is claustrophobia. Fear of flying is aerophobia. Fear of dogs, cynophobia. Fear of blood, hematophobia. Fear of injections, trypanophobia. Fear of the number 13, triskaidekaphobia. So that one's a tricky word to pronounce. But again, there's many different kinds of fears that patients can have. And so with these patients with these specific phobias, again, it may be a real fear or a perceived fear. And maybe they've never even been exposed to the thing that they're actually afraid of. Okay, all right, let's jump into post-traumatic stress disorder. That's one that definitely has been discussed pretty frequently in today's modern society because we become more aware of uh, post-traumatic stress disorder. So what actually is post-traumatic stress disorder? So this is a disorder that develops in some individuals after a traumatic event. So the traumatic event may be directly experienced by the person or from witnessing a traumatic event. Symptoms are seen as early as several months after the event, but in some individuals, it can take years for the symptoms to be exhibited. So you may be wondering, okay, well, what kind of events or what kind of traumatic events can have a person suffer from post-traumatic stress disorder? Well, could be military combat experience, physical assault, being the victim of a robbery or mugging, sexual assault, childhood sexual abuse, being kidnapped or taken hostage, being the victim of a terrorist attack, being caught in a natural disaster, observing or being involved in a fatal or severe accident. So these are all, examples, and this is not the end all be all of things that can cause PTSD, but it's a pretty good list. And so this is something to keep your eyes and ears open for as the nurse, as you're interacting with the patient. So some of the things that you're going to see with your patient with PTSD is emotional numbing. They're not able to connect emotionally with their loved ones. Okay, so they're not able to feel or express emotions. They may have difficulty with flashbacks, reoccurring nightmares. So that could affect their sleep patterns. So they may have insomnia because every time they close their eyes, they dream and they relive the traumatic event. Besides this emotional numbing, this flashbacks, kind of nightmares, they may also have mood symptoms, and so they may also have cognition issues. So they can have negative thoughts about themselves. They can have an exaggerated sense of guilt or blame. They can have a loss in previously interesting activities that they were able to partake in. They also may have what's called hypervigilance or hyperarousal. So they're always kind of on edge, looking over their shoulder, thinking, okay, is someone coming to get me? What's that sound? Wait, someone's looking at me, right? So these are all things that your patient with post-traumatic stress disorder may exhibit. And it makes it very challenging to carry out the activities of daily life. Sometimes these patients that have PTSD, they may also have panic attacks. They can have perceptual alterations or hallucinations. They also may end up with depression. Some patients that have PTSD may turn to violence, drugs, or suicide. And so it's a really, it's painful to see these individuals that go through this trauma and they end up with PTSD. So, as a nurse, one of the things that we should advocate for in our patients is if we are aware of trauma where it comes to our attention, of course, we are mandatory reporters of child abuse and elder abuse. We should report it and advocate for the patient to get the necessary counseling and treatment that they need in order to process what has happened to them, because we can prevent them from getting PTSD. And if they already have the onset of PTSD, we can help them manage this. We can help them work through this so they're able to live normal lives again. Because a lot of times individuals with PTSD are not able to have family, friends. They're not able to hold a job or go to school. They have impaired social functioning. So there's a lot that goes with your patient that has PTSD. Okay, let's take a look now at obsessive compulsive disorder. So this is kind of a twofold situation the patient has. So the patient has obsessions, and these are reoccurring, persistent, unwanted thoughts or images that cause the person to have intense anxiety. In order to relieve this anxiety about these obsessions, the patient has what's called compulsions. And these are repetitive behaviors or rituals the person engages in to reduce their anxiety. So if someone is really like neat and organized, I know we say, oh man, that's just my OCD kicking in. I've got to clean this place up. That's actually not OCD. An individual that has OCD, it affects their ability to carry out their activities of daily living. So, for example, if someone was really concerned about germs, they wash their hands 15 times to the point where their skin is peeling, and then they're late for school or they're late for their job or they can't be on time because of this hand washing, because of these rituals, then that is when this becomes a problem. Okay, so obsessive compulsive disorder becomes a problem when these obsessions and then the rituals, which are the compulsions, prevent the individual from actually living out their activities of daily living. So hoarding is also an example of OCD, okay? Body dysmorphic disorder, okay? And so let's talk about hoarding for a second. So individuals that hold on to things that in everybody else's eyes may be trash. They're really unable to release these things. And so we've seen the shows, the shows, the reality shows with people that are living in this condition and their families are not even aware, right? The families may not know about it. And the concern with this hoarding is they may be holding on to things like dead animal, carcasses. They may be holding on to trash and it becomes really overwhelming. And so it's kind of like a vicious cycle. Now, body dysmorphic disorder, this is a condition where people, a person may end up becoming addicted to plastic surgery, or when they look at themselves, they see something that they are not, right? And so it's really that they don't see their body in reality the way that other people see their body, and they may do things to try to quote unquote fix their body or transform their body into what they think it should be. So there's also another condition, another obsessive compulsive disorder is trichotillomania, and that is hair pulling. Okay, so hair pulling is just exactly what it is. And unfortunately, there's some people that they pull their hair, and patients they pull their hair and then they eat it. This is problematic, of course, because they won't have any hair. They may have, bleeding from the scalp, that kind of thing. But the other thing that is concerning is that they can eat so much hair that can actually clog their GI system. And they may have to even have, it surgically removed because they have a GI or a bowel obstruction. So it's pretty serious, and the patients may not realize that they're doing it, but this is kind of a self-soothing kind of behavior. Now, the other last disorder I'm going to discuss under obsessive compulsive disorder is is an excoriation disorder. This is scab picking, skin picking. Now, of course, we know that the skin is the first line of defense against injury and infection. So we know that if the skin is broken, that's going to increase the patient's risk of infection. So besides, being not, you want to see someone picking their scabs and then bleeding, but this is a disorder, and it's a scoriation disorder. Sometimes it's called skin picking disorder. So now you may be wondering, okay, you've told me a lot about these anxiety related disorders, right? You told me about panic disorder. You told me about PTSD, obsessive compulsive disorder, these phobias. So these are all things that could prevent our patients from living their best lives, from carrying out their ADL. So how do we treat them? So the focus is to reduce the anxiety level. A lot of times that could be done with help from anti-anxiety medications, also called anxiolytics. And these are medications that are used to counteract or diminish anxiety. Anti-anxiety medications really are important, but we have to pay close attention to the use of them in our geriatric patients, because geriatric patients should definitely receive a smaller dose, and this goes for all things with geriatric patients. We know that their metabolism is slowing down, kidney function is slowing down, liver is slowing down. So you always want to give the smallest possible dose that could be effective for the patient. So with, again, this patient with anxiety, we're looking at these anti-anxiety medications, and we always couple this, not only the treatment, not only with medications, but some kind of therapy. It could be individual therapy, group therapy, family therapy. There's going to be some kind of therapy that always goes with this patient's treatment care plan. We want to teach the patient positive self-talk to replace those negative thoughts, and we want them to be productive, right? Those are all really important things when we're talking about your patients that have these conditions. So here's some anti-anxiety agents. So in the 50s, Librium, Valium, they came out, and we know that these are very addictive and they have various side effects to look out for. Now we have benzodiazepines, and in your textbook on page 137, it gives you a list of the benzodiazepines, and some are short acting, some are long acting. So we have your alprazolam, your lorazepam. Those are short acting ones. Long acting is your clonazepam, your diazepam, right? So those are just some examples of these benzodiazepines that you can see. So the thing that the nurse has to remember is that these benzodiazepines can be addicting. They're less addicting than your Librium or your Valium, but they can be addicting, and there is a possibility that the patient can develop a tolerance to these medications. So we really want to be looking out for those kinds of things with our patients. Also, another type of medication that can be used is antidepressants, which are your SSRIs. Okay, selective serotonin reuptake inhibitors. And this is going to be given for long-term anxiety treatment. So anti-anxiety agents are also used for patients that may be in alcohol withdrawal, that are experiencing what we call delirium tremens. These anti-anxiety medications can also be used for patients that have epilepsy, or if they have a convulsive kind of disorder or seizure disorder. Status epilepticus is really life-threatening ICU kind of a seizure that the patient has, that it's repetitive seizures over a short period of time or a long seizure. Now, what is a seizure? A seizure is uncontrolled electrical activity in the brain. The patient will lose consciousness. They will be flexing, they may be contracting, and they may have the eyes rolling to the back of their head. And so there's a lot that goes on with the seizure. So let me just take a quick sidebar and mention, what should I do if, as a nurse, if a patient's having a seizure? Well, our number one thing is to make sure that they're safe. We want to protect their airway. We don't want them to hit their head, right? We're going to place their head on a pillow, or if you're out somewhere in the mall, get a jacket or something, place their head on a pillow, turn them on their side, because sometimes with these seizures, there are secretions. So we want to turn them on their side so we can maintain a patent airway. Loosen any restrictive clothing, and know that you should be monitoring, timing how long the seizure takes and what is actually happening. Is the patient contracting? Are they flexing? Are they clenching their teeth? The eyes rolling in the back of their head? You need to kind of document that and the time. Once the patient comes out of their seizure, they may be confused, they may be tired. So again, safety is going to be of the utmost importance. In a hospital setting, the patient that has seizures or history of seizures or has epilepsy, they may have padded side rails. A fall mat should be there, and the bed should always be in the lowest possible position, right? But these are some of the things that you have seizure precautions. And again, no, and this is important. I did not say this, but this is really important. Do not put anything in their mouth. Do not put a spoon, a leather strap, or a wooden stick, especially your fingers, because if a patient is having a seizure, they can bite your fingers off. Okay, so please don't put anything in their mouths. Okay, let's see. So just talking about these anti-anxiety medications or agents, and sometimes these anti-anxiety medications can be used for neuropathic pain, and so that's neuropathy, that's nerve pain, okay? And so anti-anxiety medications can also be used to prepare a patient that's getting ready to have a procedure where they have to have sedation. Okay, so if a patient is taking these anti-anxiety agents for long term, we're going to have to gradually reduce the dose. We can't just stop them cold turkey. Okay, that's going to be really important. Okay, now contraindications for these anti-anxiety medications. Patients that have hypersensitivity, of course, to the medications, and of course, patients that are allergic. But narrow angle glaucoma, and if the patient also has a pre-existing central nervous system condition or psychosis, patients that are pregnant should not take these medications, and patients that are lactating, and anyone that is younger than 12 years old should not get these anti-anxiety medications, okay? And of course, if the patient is in shock or in a coma, they should not receive anti-anxiety medications either, because these anti-anxiety medications calm you down, slow things down. So we don't want to administer that kind of medication. And of course, we don't want anything that would harm the developing fetus. Again, with your older adults, we are going to use these medications with caution, and that's pretty much with anything you're doing with your geriatric patients. They are a high-risk population as well as our pediatric patients, so they're very young and they're very old. We're going to watch out for them. And in our older adults, we're going to look at their kidney function. We're going to look at their liver function. We're going to monitor those lab values that tells us about the health of the kidneys, the health of the liver, right? So for the kidneys, that's going to be your BUN, your blood urea nitrogen, your creatinine, right? We're going to be looking at their sodium levels. And for liver, we're going to be looking at their liver function, their ASTs, their ALTs. We're going to be monitoring that to make sure it's within normal limits. Okay, that's going to be really important, looking out for signs of jaundice, because we know if the patient is jaundiced, that tells us that there's something going on with the liver. We also want to be careful with these anti-anxiety agents with patients that have a history of substance abuse as well as depression. Again, we are concerned about dependence. We don't want our patients to become dependent. So other nursing interventions, right, when we are talking about treatment of of anxiety, we want to monitor this patient's mood. We want to look at their orientation. How are they doing? Are they able to function? Take their blood pressure. We're going to take their blood pressure when they're standing, when they're sitting. We're going to look out for any paradoxical excitement. So when we think about paradoxical excitement or paradoxical reaction, this is the patient that has an unintended paradoxical response. So it's the opposite, right? The medication is supposed to make them sleepy or rest, but it might do the opposite in a particular patient, right? So it might make them more excited instead of calming them down, right? So this can happen with benzodiazepines, and what you might see in your patient that has this paradoxical excitement is excessive movements, agitation, talkativeness, impulsivity, irritability. And so this excitement is not what you're expecting if you give someone a benzodiazepine. You expect them to calm way down. Okay, so again, we have to look out for that because that could be how this patient responds to these medications. So blood dyscrasias, okay, so blood dyscrasias is really considered something that's going on with the blood. And it could be your bodily fluids, just not the blood, but blood. It could be dealing with bile, it could be with lymph or your mucus, right? So that's what we're talking about when we have blood dyscrasias that we have to look out for in our patient, okay, when we are treating their anxiety disorder. Okay, so we also have to offer strategies to relieve dry mouth because dry mouth is a potential side effect as well. We have to teach the patients to ingest medication with food and milk and always look for potential side effects. That's going to be very important. So again, with this, thinking about your nursing actions, always think in terms of the nursing process, right? The nursing process, we think about the assessment, we're collecting information, right? How is the patient's thought process, their mood, their affect, how are they communicating? How is their physiological response? How are they able to complete tasks, right? This is always important when we talk about the nursing process. When we're planning for our patient, right, we're going to be planning and we're going to be looking at, okay, what am I going to do for this patient? What am I going to implement for this patient? And again, with anxiety and with anything with mental health, your primary concern is that the patient's going to be safe. Then, if it's anxiety specific, we want their anxiety to be reduced to a manageable level so they're able to carry out their ADLs. So whenever you have these goals for your patients, these interventions, you're going to evaluate them. Okay, is the patient now able to have a reduced level of anxiety? Are they able to carry out their activities of daily life? Are there any safety issues? Now, thing that we also have to educate our patients on is when they're taking these anti-anxiety medications, they may become sleepy. So, driving a motor vehicle, operating heavy machinery, being responsible for small children is not something that they need to do. Okay. And they need to watch out for any potential adverse side effects and report them. Okay. Also, if the patient is taking any over the counter medications, they need to report that as well to make sure that there's not any contraindications with their over the counter medications or supplements with their prescribed anti-anxiety medications. Okay, and so we also want to look at the patient, assess them after we've got the treatment plan in place. Do they have any symptoms? Do they have any physical symptoms? Do they have issues with their heart, perspiration, nervousness, jitteriness, right? So all of these things are really important to assess and evaluate in your patient. Can they communicate well? right? So questions may result in the client thought blocking. So that's really an important term that we have to take a look at when we talk about thought blocking. Okay, so with your patient, if you're asking them questions, you have to look out for thought blocking. They may just, you're asking them questions, they may be talking to you and they may stop mid-sentence and they just stop talking or they stop thinking or they lose their train of thought. And this is very common, especially amongst your schizophrenic patients, as well as other patients that have, mental illness, but it's common in your schizophrenic patients, your patients that have psychosis. And so they just stop speaking and they can't really get their train of thought. Okay, so that's important to look out for your patient. Okay, that's taking these medications. All right, so interventions, again, we're going to be always our interventions. We're going to use SMART goals. They're going to be specific, measurable, attainable. Is this patient actually able to achieve this, right? So if I told you one of my goals was to be in the WNBA, you would say, okay, that's not attainable for you because you're, less than 5'5", and also you're over 50 years old. This is probably not going to be the plan for you, right? So it might not be the best goal for you. Okay, so we also want to help them with coping strategies. That's always a great thing to do. And we want to evaluate, does the patient realize what's causing anxiety? Do they know how to identify their triggers? And do they have these coping strategies to deal with their triggers? All right, now let's go ahead and take a look at question number 1. And you're going to pause the video so you can take a look and try to answer it on your own. So tell whether the following statement is true or false. The obsession aspect of obsessive compulsive disorder, OCD, refers to repetitive behavior. Is that true or false? Pause the video and answer the question. So it is false. Obsession refers to the recurrent, persistent, unwanted thoughts or images that cause intense anxiety. Okay, so those are the obsessions, and the compulsions are the actions or the rituals that the individual does to allay their fears, okay, or their anxiety. All right, here's question number 2. Which disorder is characterized by mental reruns of an event, emotional numbness, or an avoidance of people and places associated with the event? Is this agoraphobia, obsessive compulsive disorder, generalized anxiety disorder, post-traumatic stress disorder, or panic disorder? Pause the video to figure out what your answer is. And the answer is post-traumatic stress disorder. A person who has PTSD, they experience these mental reruns, and that's also called flashbacks. They can have nightmares. They experience emotional numbness, right? The avoidance of people and places associated with an event. And the disorder usually occurs following a situation that involves a death or a threat of a severe injury, right? Some traumatic event that has taken place. All right, question number 3. Tell whether the following statement is true or false. A person with agoraphobia is often unable to leave their home. Pause the video to determine what is the correct answer. Okay, so this is true. A person with agoraphobia often chooses to remain in familiar home surroundings where they know they'll be able to escape. At this time, this concludes our discussion of Chapter 9 on anxiety disorders. And remember to always think like a nurse. Thank you.